Hello, I'm Richard Vincent, and I'm glad to be with you today to talk about the work that I've been doing at Mount Sinai Hospital. And my background is I'm an architect by training and a technology management specialist in looking at lighting technologies for um, disinfection of pathogens, both airborne and surface-borne. I was the director of research at the Lighting Research Institute in the 1980s when I was contacted by St. Vincent's Hospital to look at applying UVC technology to interrupt the transmission of tuberculosis in homeless shelters in New York City. And so that's how I began my work in the germicidal UV area. And I'd like to talk to you about some of the work that I've been doing in my career and how I've mounted hospital-based studies, which is quite a interesting challenge to try to deploy UVC technology in active hospital settings. And so that's a little bit about what we'll discuss today. We are looking at how to use UVC disinfection technology during the pandemic. And there's been a lot of interest in this. I gave one webinar where we had over 3,000 people join it from 59 different countries. And so there's been a wide interest, especially during the pandemic, because people are in lockdown and yet still want to understand how technology can help us in disinfecting the air and surfaces that are contaminated with COVID-19, the SARS-CoV-2. And so we'll talk a little bit about how UV works and where it's being used and how we're doing research at Mount Sinai to improve the knowledge of this. Dr. Bruckner is my collaborator. As I discussed, he was the father of homeless health care in the United States. His work involved the McKinney Act from Congress to supply funding to do preventative health care in homeless shelter settings. And so when there was an outbreak of TB in the 1980s, early 90s, he thought about UV that he had been aware of when he was an intern resident at Bellevue Hospital in the 1950s. Since that point, antibiotics had been used, and so everybody took down the UV lights. But here he was staring in a 1,000-man bedded shelter under the Triborough Bridge in 1989 and saying, why don't we hang some more of these UV lights, because there was active TB being transmitted in these shelters. And nobody knew what he was talking about. So in my role as director of research at the Lighting Research Institute, I was contacted by Dr. Bruckner to help explore how to reapply UV in high-risk settings. And so what we've been doing through our decades of work in this area is trying to look at what is the evidence base for medicine of applying this technology. How does it provide for patient and staff safety? How does it affect the bottom line as healthcare institutions? We always have to look at how technology is applied wisely so that it can influence in a better way the economic condition of the hospital. And then as an architect, I always want to know that when I'm applying technology, that it is evidence-based and know where it should be applied, where it shouldn't be applied, how it's commissioned and operated and maintained. And so in our work in the UVC area, we've looked at various stages of development. And I think this is apropos to the Thrive grouping, because sometimes there are different stages of development of technology. You can have something that's in its infancy, it's emerging, but not evidence-based. It can be maturing, where it's being demonstrated and applied, but not fully understood. And then it's mature, where it's well understood, it can be applied with confidence. And then the other aspect is, how sustainable is this? Many times in the work that I've done internationally, people wrote grants, got UV fixtures, applied them, but then had no money to maintain them. So they became ineffective because there wasn't finances or a budget planned to keep it sustained. And so that's part of the work that we've been trying to do in educating people about the use of these technologies. So there are various airborne pathogens that we've looked at, tuberculosis being the one of the primary ones, because over 1 million people every year die from tuberculosis disease. And it's, of course, co-infected with HIV in many countries. And it kills people on a very regular basis. People can be reinfected with TB, and there are extensively drug-resistant strains of TB circulating in the world. And so it becomes a very deadly combination with poverty and poor ventilation, et cetera. So this is one of the primary uses of upper room UV that I'll describe. We've looked at it as far as influenza. After the bioterror attacks in the United States in around 2001, we began to explore use of UVC as a bioterror countermeasure. And of course, that could be true for the SARS-CoV-2 because it's become a pandemic, and there are some aspects of it that seem to be almost bioterror related, the way it was so virulent in its strain. Of course, this is one of the things you've probably seen this slide. It's a strobe slide of somebody sneezing, and the droplets that are here close to the mouth are the larger droplets that will fall by gravity to the floor. Of course, it's these that we're concerned about with SARS-CoV-2 because the droplets can land in eyes, in mouth, or nose and cause infection. But it's this outer part where the droplets still will contain a lot of virins, but they are floating on the air for long periods of time and can then also infect people. And this is where the potential for upper room UVC is an important area. Of course, how do you contain these viral particles, you know, if you're doing high flow ventilation for patients being treated with COVID? And that's one of the projects we'll talk about as well. UV comes in a number of wavelengths. UVA, UVB are found in the sunlight. UVC that we're talking about has to be artificially generated by electric lamps. And so this is a part of the work that we're looking at. You have UVA, which is more carcinogenic, these types of things that are found in sunlight. UVC is a very non-penetrating form of irradiation. It rarely goes through the stratum cornea of the skin, and so therefore it doesn't get down into the germinative layers of the skin, and therefore will not cause damage. There's several orders of magnitude more UV out in sunlight than there are in the building applications that we're describing. And also 254 nanometers is the primary wavelength that has been used for germicidal UV, although there's been a lot of interest in 222 nanometer by Dr. Brenner at Columbia University. And then we're also exploring 275 nanometer range of UV LEDs, and I'll talk about that a little bit. And why germicidal UV is important is if you look at this curve of DNA disruption, at the peak of that is 265. And so UVC is more right in the 254 nanometers, very close to the peak disruption of DNA, and for the virus, for RNA. These are the types of lamps that generate UV. These are the low pressure mercury lamps. These are kind of the workhorse of sources that are used to generate UVC in the 254 nanometer range. These are the germicidal UV LEDs, and they range from 265 to 280. And then these are the new excimer krypton chloride lamps that are being touted as a safer form of UV. You also have to have the right type of radiometer to measure whether you're getting the right amount of UV out, and it's wavelength specific. And so these are field assessment meters. We're using these in the BSL-3 lab at Mount Sinai to study COVID against UVC sources. This is another type of radiometer with a different screen. This is a study we're doing at Morningside Hospital. And here we're interested in looking at what kinds of environmental organisms are left on patient sinks, on the handles, on the surface of the sink, inside the bowl, and down the drain. And so underneath this lamp, there's a series of UV LEDs that are shining onto the surface. It has a sensor so that if somebody is coming in to use the bathroom, the sources will be turned off. And as soon as there is no one present in the room, then they would cycle on and go over an 8-hour period of time and provide a dose. Also, we've put a UV LED inside of the drain because there can be organisms growing inside of the drain that can be aerosolized through water going down the drain and being aerosolized into the room. So this is we're just starting this study right now, and we're excited to see how that will turn out. All right, 2 of the studies that we are doing, there's a team of us at Mount Sinai and RPI that are collaborating on a number of UV related studies. One is to develop an exposure chamber to capture the aerosols from the high flow therapy that's going on. And this is a collaboration between Dr. Rappaport in the Sleep Center and an inventor from the DOD. And a whole team of us are looking at how to put UV lamps inside of the chamber to irradiate the aerosols that are being generated and then be able to discharge those safely into the room. The other thing that we've been looking at is how to extend the use of PPE during a pandemic. And there was a study out of Nebraska and the Mills study that showed that it was possible to irradiate respirators and other PPE with UVC 254 and allow them to be reused. I think they talked about using them 3 times because one of the things about UVC in the respirators is they can break down the material, the plastic bands and other things, and lose integrity. So therefore you wouldn't have a tight seal when you're trying to use the respirator. So we've studied SARS-CoV-2 on these respirators, and we found that it was very easy to inactivate. We're in the process of writing a paper, so I can't give away the bottom line, but it was very promising. And there's been a whole system that's been developed and is being put in for emergency use authorization. So that's been a very interesting study to be a part of. Then we're looking at a study on these excimer lamps. Here you'll see one of the lamps that is lit, and we had a radiometer, and we're measuring the output of these sources. And then we want to do a demonstration of their use, maybe also within a bathroom at Mount Sinai. So these are some of the things that we'll be looking at as new technology comes out. The rest of my talk, I'll talk a little bit about the upper room UV because it's an important intervention for airborne transmission of pathogens. It works both with natural as well as mechanical ventilation. It's been shown to be 80% effective in reducing the transmission of airborne pathogens such as tuberculosis. It works against a wide range of pathogens, and the systems are relatively easy to maintain, and human safety can be achieved with proper design, installation, commissioning, operation, and maintenance. So this is what we see in many parts of the developing world. You'll have a crowded patient waiting room, the OPD, and there's no way that ventilation or UV would be able to stop transmission. So you have to have administrative controls to decompress the number of people occupying the space And so that's part of what we're doing now in the States of having people screened when they come in, having fewer people occupy spaces, social distancing, all those types of things. And then you can add the environmental controls such as UV. And when COVID started, we looked at how UVC would work against the pathogen. For BCG, we found that it was taking about 16 microwatt seconds per centimeter squared to get a 90% reduction. In a similar basis, we looked at the Walker and Co. paper, and this was on a surface, and it showed for a coronavirus about the same amount of energy would be required to inactivate it. And so these were some of the earlier indications of what type of dosing would be needed in order to inactivate COVID. How effective is upper room UV? Dr. Riley, he was an MD and scientist who studied UV for many years, and at Johns Hopkins, he was able to close off his office on a weekend in the 70s. You couldn't do this now. And he sealed it off and then aerosolized BCG into his room. And he found out after a period of time that just the decay rate of die-off was about 2 air changes per hour. That means that like the whole volume of the room was changed over 2 times. And then he turned on a UV light and found that he added an additional 10 equivalent air changes per hour to a room. So the way we think about air changes, every air change removes from a room about 63% of whatever pathogen might be in there. And that's the way ventilation is normally sized. But with the UV, we consider that as an equivalent amount of ventilation, removing the pathogen infection potential by UV. There was a study done in South Africa where patients in an active TB ward had upper room UV fixtures placed in there, mixing fans to make sure that the air was well mixed so UV could treat it. And then on days when the air was irradiated, it would go to one group of guinea pigs. On the other day when it was irradiated, it'd go to another group of guinea pigs. They became the air samplers for this particular study. And then over a period of time, it showed that there was about an 80 to 90% effective rate, or the equivalent of 24 additional air changes. And this is being used as the means of dosing upper room facilities today. And so UV guidelines are based on real patients, biological endpoint of infection, and then looking at how much UV is required to inactivate the organisms. And then we've developed through our research a study that enables a lighting software package to calculate UV in the upper room. The WHO has taken a review of the UV research that's been done, and it is one of the recommended interventions for airborne infection prevention and control. And this is the way UV works in a patient room. As the air currents bring the pathogens up into the UV disinfection zone, they become inactivated and pushed down into the lower part of the room and dilute the concentration of organisms in the lower part of the room. And so we have 3 steps for programming UV into a upper room space. We first start with this dosing criteria, multiplying the room volume by this dose, and that through that we find out how many fixtures are required, and then using the CAD program, we refine the study until we come up with the proper target fluence in the upper room of 6 microwatts per centimeter squared on average. A lot of times we need to apply ceiling fans to ensure that there is a mixing of the air up into the disinfection zone. This can also be done by mechanical ventilation as well. This was the tuberculosis ultraviolet shelter study that Dr. Brickner and I and Dr. Nardell from Harvard School of Public Health did together with other colleagues. And we put in over 1,200 UV fixtures in 14 different homeless shelters in 6 US cities, and ran this study over 7 years and learned how to apply this safely. And this is a church fellowship hall near Grand Central. And in there, we place these upper room fixtures on this side, and you can't see it, but on the other side of the room, we had a similar, a number of fixtures shining across, and then the air coming out of the supply grills allowed mixing into the room with the UV. And so we also measured the output from these lamps on a regular basis and then replaced them when they fell below a certain criteria. So this is the computer design tool that we talked about, and it can calculate the NIOSH dose that was recommended as well. This was a cancer infusion center in Butaro, Rwanda, where one of the students at a course that I taught with other colleagues at Harvard learned how to use this CAD tool and imported their design for this cancer infusion center into Visual. And here you can see low velocity fans and UV fixtures inside of the naturally ventilated cancer center. And this is how we're looking at big box applications like Costco or Walmart, places where you have very high ceilings and large volumes, and visuals being used to calculate what is the eye level irradiance that's being generated by the system, so it can be at a safe level. And then it also talks about how much UV on average is in this upper room. And so this has been a real benefit as people are learning how to apply this technology. And that's been one of my things that I've been doing during the COVID, is teaching many people about how to apply this technology and these software tools. And then there have been various studies that have been done in the 40s and 50s. Here was a study in the school system outside of Pennsylvania, Philadelphia, and there was a series of schools that had UV in their classroom, and the classrooms that had the UV had a very low level of outbreak of measles during an epidemic. Those that were in the unirradiated rooms had higher levels of measles, and so this was a kind of a proof concept in a sense that UV would work inside of an epidemic, inside of schools. And here's a picture of that installation from the 1930s, early 40s. And you'll see up on the bookshelves, these are two UV upper room lights. They had very tall ceilings. They reflected it off this area, and the students were safely doing their studies below. Here's a modern representation on the right-hand side where you have upper room fixtures in a school setting. I think this could be a great opportunity to apply it in schools to keep not only the students, but as well as the teachers safe from this epidemic. This is a hospital where we applied UV inside of a naturally ventilated hospital in Karachi. And then this is where it's applied in the waiting room at the Kings County Hospital in Brooklyn, New York. We always say that you have to, when you install it, you also have to monitor it and make sure that it's safe. And then this is how it looks when it's occupied. This is a major TB center in New Delhi, India. So one of the questions people always ask, is this technology ready for prime time? And one of our supporters of our TB-UV study said about upper room, is it ready for prime time? So we tested it by going to one of the major realtors in New York City. And when we got there to talk about upper room UV, he said, I'm not so interested in that, but here I've got a problem in my air duct. So that led to another study where we looked at providing UV inside of an air handling unit that would provide air into a building. This also was shortly after the anthrax attacks in Washington and other places. And so we tested a novel air duct to be able to see whether UV inside of an air handling system could handle a threat of bioterrorism. And we found that it was about 88% effective from a B. subtilis spore, which is a surrogate for anthrax. And this was written up in the Journal for ASHRAE, which is a major air conditioning society. And then we've been asked to look at mobile robots or whole room UV applications. We did a study at Harvard looking at these UV robots and how effective they were. If you were directly in front of one of these units, you could get greater than a 4-log kill. But if it was at the side or at the rear, it was much less. So a lot of the strategies about using these mobile units is that you have to place them in a couple different locations to make sure that shadowed areas get enough UV in order to inactivate them. We were trying to find a means to be able to compare different units. Some of these can range up to $250,000, others are $150,000. So it's an expensive piece of disinfection technology, but there's no guideline right now as to how to sort out which is better than which or how do they compare. So that was part of the study that we were doing, is to try to develop a way to benchmark these types of units. But there have been studies that show that they are very effective against MRSA, C. diff, other various pathogens that can be on high-touch surfaces for long periods of time. So they do have a means of enhancing hygiene in rooms after they've been terminally cleaned. We also did a study a couple years ago looking at how we could decontaminate all the stuff that comes on our phones. We're constantly touching our phones, and there's a concern about maybe cross-contamination of our phones to patients. And so there was a device where you could insert your phone on this quartz glass plane, close the lid, and 30 seconds later come out with a clean phone. And we tested that using some medical personnel on in the emergency department and in one of the medicine floors, and found it was very effective. We also asked people where they kept their phones, and those that kept them in their pockets or at their desktop were less contaminated. So it was a very interesting study. I think it could be a very good use of UVC during a pandemic as well for cleaning our phones mobilely, or tablets or other types of devices. We've also looked at a narrowband spectrum of white lighting technology, 405 to 420 nanometers. We installed this in the Jack Martin Clinic in the CAM building on campus at Mount Sinai, and looked at environmental cultures of various surfaces. This is a very slow-acting disinfectant. It did not work very well from our viewpoint in our studies, but later studies that were done at Duke University showed that you could get 1 to 2 log reduction of surfaces, but it would take a week's time for it to actually start doing its work. So it wasn't a very efficient way of getting immediate disinfection, but over a long term, it did have some potential. These are some of my collaborators from various studies. And I think that is all that I wanted to say, and I hope you enjoyed this. I look forward to any questions you'd like to offer.